Good morning, everyone. We are going to get started. I know folks will be filtering in, and because of the rain for our speakers, we may have more folks on Zoom than in person. But that said, Happy New Year. Good morning, intentionally or unintentionally timed with dry January. We have a bit of a substance use bang to start the year off at HIV Grand Rounds this year with tobacco and alcohol this session, and next week methamphetamine focus. So yes, happy dry January, happy New Year, all the things. We're really lucky to have two phenomenal speakers focusing on the management of alcohol and tobacco use disorders in people living with HIV. And as I introduce them, just a reminder to log into pollev.com /HIVGR to get ready to participate in the audience response. And without further ado, our first speaker is Dr. Triveni DeFries, who's an assistant professor of medicine at UCSF in DGIM here, who's fellowship trained in addiction medicine and is the director of the UCSF Health and Human Rights Initiative, is a physician consultant on the Substance Use Warm Line. If you've ever given them a call, you might have talked to her, and has recently been consulting with the HALT clinic at UCSF, which is the Healing Alcohol Associated Liver Disease Together clinic that's aimed at getting more folks to transplant with alcohol use disorder. Dr. Maya Vijayaraghavan is an associate professor of medicine at UCSF who directs the UCSF Smoking Cessation Leadership Center, where she's focused on eliminating disparities in tobacco use prevalence through multiple trials that support smoking cessation in people experiencing homelessness. So we have two fantastic experts here to take us through the next hour. Triveni will speak first. Triveni, I'll give you a 5-minute warning. We'll take questions in between and then transition to Maya. Let's give them a warm welcome.
Thank you, Aisha, and thanks so much. It's great to be back. I actually gave a talk at HIV Grand Rounds on this topic 5 years ago. And so preparing this really had me reflecting a lot on how much has changed and how much has not changed, how much has gotten worse. And so today we're going to talk about really updates in the literature and in our care system in San Francisco with regards to unhealthy alcohol use, rather than kind of go through the mechanisms of AUD med prescribing. But we'll talk this through 3 different cases. And I'm going to jump in because we have a lot to cover in 20 minutes. This talk is entitled Legal and Lethal, and unfortunately on the lethal end of things, there are a lot of updates to share from data and statistics about how the mortality related to alcohol use has just worsened so much since the COVID pandemic. In this large study of US mortality data recently, it estimates that 13% or 1 in 8 annual US deaths are attributable to excessive alcohol use. And in our state in California, 1 in 4 deaths among younger folks 20 to 34, and 1 in 5 between folks 35 to 49. So just an incredible burden of mortality here. And we're going to talk about evidence-based sort of individual level treatments. But I want to say that really big picture here, to impact and prevent these deaths, there's really a need for broader implementation of population level prevention and treatment strategies. In San Francisco, how do alcohol health indicators look? Well, here in blue and black, you'll see that alcohol-related deaths rose, and in red, treatment admissions for alcohol use disorder decreased, all along with the timing of COVID, and we have not returned to pre-pandemic levels. Alcohol is often the elephant in the exam room when we're working with patients, and this is really no different in HIV care. Alcohol has been associated with HIV transmission, delays in engaging in care, disease progression, lack of viral suppression, impacts care and retention in care, and is associated with a lot of really common comorbid conditions. And just like for any substance use, alcohol use occurs on a spectrum. So I use the term unhealthy alcohol use in this talk, and that's really an umbrella term, and it spans from risky use, which is drinking above the safer, what are currently recommended as safer drinking limits, all the way to alcohol use disorder as people develop more negative life consequences of use. And we can tailor our interventions to where people fall on the spectrum. So for people who are drinking above safer limits, A brief counseling intervention has been shown to be effective in US primary care settings, but for people with a more severe alcohol use disorder, a medication really should be prescribed. And the AUD cascade of care shows us that unfortunately we're really underperforming in that prescribing of medications. So in a large study of a national survey on drug and alcohol use, it shows that even for people who've used healthcare, who've engaged in healthcare, have been screened and identified to have AUD, less than 6% of people receive any treatment. And from that same data, very few people receive pharmacotherapy as part of their treatment, so less than 2% nationally. And there's racial disparities in who receives a medication. So studies from the VA show that Black patients, for example, are less likely to be prescribed a medication for AUD. So a huge, huge treatment gap to take on. And with that, let's jump into our first case, which is about medications for AUD. So our first case is a 45-year-old man. He has HIV, depression, severe alcohol use disorder, hypertension, and he's following up with you for abnormal liver tests. He's saying, his goal, he really wants to stop drinking, but short term, it's more realistic for him to cut back first. You rule out other causes of liver disease in your workup, and here are his labs with respect to his liver and kidney function. And you do see that his recent ultrasound shows cirrhosis. So which medication for alcohol use disorder would you be most likely to recommend for this patient? And I believe everybody should be able to vote. And as you're, should I go to the next slide or is this? Yeah, and as you're voting, I'll just tell you that you're plugging in these values, you're trying to get a sense of his liver function. And one thing that you can look at is his Child-Pugh score, which is a mortality score for people with cirrhosis. And when you do that, you plug in all the information here and he is Child-Pugh class A. So he has compensated cirrhosis. Awesome, okay. Acamprosate and naltrexone, and most people favoring naltrexone. Cool, so let's explore that. So this patient has alcohol-associated liver disease, or ALD, which includes several liver disorders, including cirrhosis, including alcohol-associated hepatitis. And the COVID-19 pandemic really has, as I said, led to all of these harms of alcohol use, including increasing rates of ALD in the US. And ALD is now the leading indication for liver transplantation in the US, has eclipsed hepatitis C. And there are very low rates of AUD treatment in this population, even though these actually might be patients who need treatment the most. So in one really large study, they estimated that 0.4% of patients had received pharmacotherapy if they had cirrhotic stage ALD. And part of that has been this barrier of limited data about the safety and effectiveness of medications for AUD in the setting of liver disease. These are often patients who are really medically complex, and there hasn't been a lot of data to guide us, and there's been concerns about the hepatotoxicity of naltrexone. But there's a few small, well, not even small, there's a few studies out there now that are starting to help guide us in the direction of treating these patients more aggressively. So here is one large retrospective cohort study of over 9,000 patients with alcohol use disorder over almost 10 years at a single site where they actually happen to have pretty higher than average rates of AUD med prescribing. And in multivariate analyses, receiving any AUD pharmacotherapy was associated with a decreased incidence of ALD and a lower incidence of hepatic decompensation in patients with cirrhosis. And for patients with ALD, these associations were strongest for naltrexone, gabapentin, and topiramate. And there was a finding that acamprosate, which has a favorable liver profile, so it's often used in this setting, actually was associated with an increased risk of ALD. And that likely had to do with the fact that higher risk patients were chosen for acamprosate treatment. But these results suggest a benefit of naltrexone in patients with cirrhosis, which many clinicians have avoided, as I mentioned, and also the importance of non-FDA approved medications for patients with ALD and AUD. And to quickly review our menu of medications for AUD, 3 of them are FDA approved: naltrexone, acamprosate, and disulfiram, and several have been studied for the use of alcohol use disorder and are used. And I've bolded here the ones that are considered most first line and are most commonly used. And all of these medicines have very different mechanisms, but they share several features in common. They're safe, they're well tolerated, they have very few medication interactions with the exception of disulfiram. They can all be combined with alcohol if somebody's still drinking. And they can be started and stopped pretty quickly and easily and can be combined with each other. And here's a summary of an approach of how to select medications for AUD. And in that approach, I suggest targeting two things. One are the patient's goals, because these medications have been studied with differing effectiveness for two different goals, reducing the amount that somebody drinks or total abstinence, and then also targeting comorbidities. So our patient has compensated liver disease, but for somebody who is decompensated, you'd be more likely to use a camprosate, gabapentin, or topiramate. If that person has adherence challenges, we have the option of extended release naltrexone. If someone's got concurrent opioid use, we'll be avoiding naltrexone, but interestingly, and maybe you'll hear this next week, if somebody has concurrent stimulant use, extended release naltrexone could be an option for both stimulant use disorder and alcohol use disorder, as is topiramate. Renal disease means you're going to dose reduce a camprosate and gabapentin. And gabapentin actually can be particularly useful for people with anxiety, insomnia, or a history of withdrawal. My last update on ALD, alcohol-associated liver disease, asks the question, if liver transplant outcomes are different if patients don't meet the traditional 6-month abstinence rule, which so many of us have practiced with for so long. And this retrospective cohort study from 2021 compared outcomes in patients with earlier liver transplantation, less than 6 months of alcohol cessation versus standard 6 months in one institution over 8 years. And it found no significant difference in the 1-year survival or return to alcohol use. And so several institutions, including UCSF, have introduced new candidacy requirements for individuals with alcohol use disorder. So it's really worth referring your patients early and often because things are evolving so quickly in this space. So in summary, for our first case, which is about the selection of medications for AUD in co-occurring liver disease, naltrexone, topiramate, and gabapentin all are great options. I often consider naltrexone first line if a person can get it. These could even be combined with each other if you wanted to start more than one medication or add one. And for support for these patients, you can refer folks to UCSF Halt Clinic, which is where Aisha mentioned I've been providing addiction medicine support along with a counselor and a hepatologist. And you can also refer to Bridge Clinic over here at SFGH. And support at Ward 86 also includes support from the nursing team in providing extended release naltrexone, which can be ordered to the SFGH outpatient pharmacy, delivered to Ward 86, and then given in the treatment room. So we will move to case 2. Case 2, we have a female patient who comes to you and says, something is wrong when I try to stop drinking. She's experiencing alcohol withdrawal symptoms, and she's saying, I can't stop on my own. What do I do? You ask some questions and you notice that she has one hospital admission for alcohol withdrawal, and she has a history of alcohol withdrawal seizure, but she hasn't had a seizure in the last month. And she recently lost stable housing. So things have been a bit chaotic for her recently. So what do? You send her to the ER right now. You start gabapentin, continue naltrexone, or do some combination, consider benzodiazepines, or do some combination of B through D. Okay. Awesome. We have good test takers and very interesting. And then some folks thinking we got to send this patient to the ER. So only a portion of patients who stop drinking or abruptly reduce their drinking will experience withdrawal. So it's really important for us in making a plan to understand which patients are most at risk for developing severe withdrawal. And a review of the literature found that it is a history of delirium tremens, DTs, that was most predictive of this, at least in hospitalized patients. And so here's a screening tool. It's called the Prediction of Alcohol Withdrawal Severity Scale, or PAWS, and it can be used to predict severe withdrawal. It's been validated in medically ill inpatients, but I do actually think it can be a helpful tool for outpatients as well. And it provides important questions that help as a guide to stratify who will benefit from prophylaxis or treatment with benzodiazepines for alcohol withdrawal syndrome. And it asks questions mostly about somebody's history. Have you been admitted to the hospital? Have you had seizures? Have you had DTs? Do you use other CNS depressants or other drugs? And in addition, some more questions can help us understand, like, well, where do we manage withdrawal? Can we actually treat this person as an outpatient, or do we have to send them to the ER? Do they have to be hospitalized or in a more supportive setting? And so we can help to understand this by asking, like, does the person have a safe environment, housing, or somewhere where they can be a caregiver or somebody who can help support them and monitor them while they're undergoing outpatient management of withdrawal? Can they be in touch, and can we be in touch on almost a daily or every other day basis to evaluate their symptoms and talk about medication administration? Or do they have really severe alcohol withdrawal syndrome right now, and that person needs to go to the ER? Are they at risk of really severe or complicated withdrawal? Do they have other acute illness or other co-occurring substance use that might make for a really complicated withdrawal picture? And those are people who all could benefit from being in a more medically monitored setting. If patients are treated with medications in the outpatient setting, generally benzodiazepines are considered first line because they've been studied to prevent seizures, but consider reserving benzos for patients who have a history of severe withdrawal or a risk of severe withdrawal. And that's because there are significant concerns about CNS depression, over administration, misuse. And gabapentin is actually a great option for treating withdrawal in patients with alcohol use disorder. It's as effective as benzos in some studies, but not all of those include seizures and DT risk. So it can be used as an adjunct to benzos or as monotherapy for mild to moderate alcohol withdrawal symptoms in the lower risk patient. And carbamazepine is an alternative if gabapentin isn't tolerated. So for our case of this patient where we're exploring the ambulatory management of alcohol withdrawal, continue their naltrexone, start gabapentin, at least as an adjunct, and it can be continued as a maintenance treatment for AUD, and then explore the patient's preferences and our local resources around getting them into a more monitored setting, because in this case, the patient had some higher risk features, a history of admission and seizure for alcohol withdrawal, possible delirium when she's withdrawing, and this unstable housing environment. And these can be very nuanced discussions and really should be focused on patient preference and individualized. And so consider referring to Bridge Clinic for support. Paula Lum and Jess Bloom are both working there now. And so they would be great folks to talk about patients with HIV who need this kind of discussion. The other reason to ask for support is that we have just had massively changing resources for our patients with regards to this detox setting. So as you know, Joe Healy closed, I think over a year or two ago now, a year ago, and we've had changing resources. There is a new detox facility that SFDPH is contracting with called Palm Avenue. It's located in San Mateo, and the patient that I described would be a candidate to go there. If you have a patient case that you want to discuss, reach out to Michelle Trong from DPH because things are evolving so rapidly. But at this moment, patients can actually be transported from anywhere on the SFGH campus. So that includes Ward 86 over to Palm Avenue. And it would require a same-day assessment by a clinician. And also at this point would require you to write the prescription for their medications. So that's our second case. And we're going to move on to our last case, which is called the nightclub. We have a 23-year-old male with HIV and nicotine use disorder. And he screens positive on the single question alcohol screener in your clinic. That question, how many times in the last year have you had 4 or more standard drinks in one sitting for a male? And that's getting asked in the BHBS screening for our patients. And on further discussion, you talk about how he's drinking more than 10 drinks a night on Saturday and Sunday nights when he goes out dancing at clubs. He feels hungover the next day, He's made some decisions he regrets, but otherwise he hasn't really had ongoing negative life consequences or real issues with controlling his use. In kind of discussing this history, you're able to assess the DSM-5 criteria, and he meets about 2 or 3, which gives him a diagnosis of mild alcohol use disorder. So what would you like to offer him at this point, or what would you like to learn more about offering him? And I'll let you all vote for a second. I find this a really fun case. Awesome. So we got safer drinking tips. There must be an app for this. Naltrexone, psychedelics. So this patient falls in the part of the spectrum of at-risk drinking. We've got him drinking above safer drinking limits, maybe a mild alcohol use disorder, but not a more moderate to severe alcohol use disorder. So typically this is a patient who gets a brief counseling intervention, but maybe there's something new here that we can give him. So we're going to go through each of the answer choices and offer just a couple updates about each of them. The first is safer drinking tips. And this is actually from Rethinking Drinking, which is an NIAAA resource, and the website's at the bottom of this page. I absolutely love this resource, and I really learn something every single time I look at it. But it provides counseling strategies around safer drinking and really specific practical strategies around, like, how do you keep track of your drinks? How do you count them, measure them? Like, how many standard drinks are you having? And I even played around with their cocktail content calculator recently. So if you enjoy like craft cocktails and are wondering how many standard drinks are actually in them, you can like customize one on there. And there's counseling strategies about like setting goals, handling urges, avoiding triggers, like building in refusal tips. And so I encourage you to look at this with patients, and there's also a Spanish language version. And these safer drinking tips they're really something we should offer all of our patients who are struggling with unhealthy alcohol use. They're a harm reduction practice, and they can be applied to patients with binge drinking, like in our case, or to patients with much more severe AUD. And one of my favorite counseling resources is also these 2 flyers. They actually come from a trial of that was done with patients with very severe AUD, and they did these harm reduction interventions along with medications using these 2 kinds of counseling tools. And they bring up a lot of interesting things for patients about how they drink, not just what they drink or how much they drink. Like, what's the setting where you drink? What are some safer settings you could drink in? Like, how could you like count drinks or maybe alternate drinks, eat before you drink, avoid mixing drugs with alcohol. So we'll go to option B here. It's January, so we had to talk about dry January. And risky non-dependent drinkers, like in our case, they may want to consider something like dry January. This is really about an exploration of somebody's relationship with alcohol. And in a study of folks that completed dry January, they really did feel a sense of achievement, had better sleep, saved money, lost weight, but at 6 months still had sustained decreased drinking without really rebound, like without drinking more at the end of January. So this may be a strategy for some of your patients who are interested in trying out abstinence, the sober curious. And then C, there must be an app for this. And indeed, there are many apps for this. So I am amazed by how many apps have been developed now. And to support a patient's own kind of self-efficacy, some patients may find an app-based program to support their reduction in drinking. And a recent trial from Switzerland showed that providing access to an app for university students actually did reduce their drinking amounts over a year. And there's many apps out there now. I don't endorse anyone in particular, but some of them are free, including the last 2 on here, Reframe and Nomo. So these are something that you could discuss with patients if it meets their goals. And so for our something really new is on-demand PRN naltrexone for our patient who binge drinks on an event-driven basis, so at the nightclub, who has a mild alcohol use disorder. And this article by the UCSF team, who might be here, is really one of the top addiction medicine publications from 2023. And this was a double-blinded, placebo-controlled RCT of 120 sexual and gender minority men who binge drank. About a quarter of them had HIV. And those that got the intervention were offered 12 weeks of naltrexone, 50 milligrams PO, PRN, that they could take when they felt craving or anticipated heavy drinking, like when they were going out at night. And they also got weekly counseling. And indeed, this was associated with reduced binge drinking amounts and reduced frequency of binge drinking. And the drinking outcomes were sustained at 6 months post-treatment. There were not significant effects on alcohol biomarkers, so people were not completely abstinent, and that wasn't really the goal of the study either. And there were not significant effects on sexual risk behaviors. But the naltrexone PRN was safe and it was well tolerated. The main side effect was nausea, and that was actually experienced in both the placebo and intervention groups. So this is really a strategy to talk to patients about. It's pretty safe and well tolerated, and it might help folks. But do note that not everybody is going to have the self-awareness in anticipating cravings and self-medicating themselves in advance. And if it's somebody who has a more severe alcohol use disorder, we should be offering naltrexone in a daily fashion, which is how it's been studied to improve outcomes. So option E, what about psychedelics? There is growing interest in prescribing psychedelic medications to treat substance use disorder. And there is a recent trial to share with respect to alcohol use disorder. There was a double-blind placebo-controlled RCT of psilocybin versus placebo, and psilocybin was given twice at weeks 4 and 8 and combined with 12 psychotherapy sessions. And it did reduce some drinking outcomes. I think there was a high risk of bias in this study. 90% guessed their treatment group, which I just had to share. But there, interestingly, were no significant side effects from psilocybin in this trial. So definitely more to come. And this in particular doesn't apply to our patient who has binge drinking, but I did want to share this update of a RCT in this space. And our last option, I started my talk by telling you that the COVID-19 pandemic really presented so many challenges and increased harms of alcohol use, but it did allow for some real harm reduction innovations. And one of those is the managed alcohol program in San Francisco, which is the first managed alcohol program in the country. And it's a residential setting where alcohol is prescribed in supervised quantities. And this is a potential intervention to consider for some of your patients. The type of patient you would consider this for is somebody with very severe alcohol use disorder who has had a lot of harms of their use. Usually this is also somebody experiencing homelessness who are not served by abstinence-based options. And so you can refer folks to be considered for this program. And I think it's a great example of something that may help our patients to not only address the harms of alcohol use, but also stabilize housing and chronic medical conditions. So in summary for our case 3, we really do have at our fingertips several strategies beyond just the traditional brief counseling interventions for this patient who's at the part of the spectrum of unhealthy alcohol use where they're experiencing at-risk drinking or mild AUD. And that's the end of my portion here. I really hope that you leave this feeling like there's some emerging, promising resources and tools at your fingertips, and that we can increase and teach others to increase their prescribing of medications for AUD to match our patients' goals and their comorbidities. So that's it. Thank you so much.
All right, we're going to take some questions. So just raise your hand and Joe will bring you the mic.
Thank you. Just great talk. And I guess one quick question is, what do you think the role of alcohol biomarkers was for this studies being evaluated, you noted one, for example, saw no difference in biomarkers. I think it was a naltrexone PRN. But also just curious about your thoughts on the role of point of care biomarkers, especially with patients fees that some extent for adherence programs. So curious about your thoughts around that.
Yeah, for sure. The question was about the role of alcohol biomarkers when caring for a patient with alcohol use disorder. I think it's such a good question. I should mention that I've recently started working with the liver transplant program, which is probably the only setting I've really been exposed to where they aggressively use alcohol biomarkers. And it's been really interesting to work with patients who are undergoing that kind of testing. For some patients, it's extremely punitive and alienating to be monitored with those kinds of biomarkers. And really, we can use our strategies in like history taking and rapport building with patients to try to be able to have open discussions about their use. On the other hand, there are some patients that do find it really helpful. I mean, yesterday I talked with a patient who said literally like, it keeps me honest, keep doing it. And so I think it really has to be individualized, but is something to potentially bring up with your patient. There are programs that specifically integrate breathalyzer testing into outpatient management of alcohol use disorder. And there's actually a new online telehealth program. It's called RIA that a lot of insurance companies are contracting with. And actually you may see some of our patients working with them. And they do AUD med prescribing, counseling, and they incorporate breathalyzer testing into it. So again, I would individualize it to the patient. But an important takeaway is if your patient may be heading towards liver transplantation or is in that journey and they have periods of abstinence, it might actually really be in their interest to document those periods of abstinence. And so if it fits for the patient's goals, you could consider getting PEth testing, which is a blood test, or there's urine testing as well, to really just start building in that history to advocate for them.
Thank you. Excellent information. I just have a question about baclofen. A number of patients that I've worked with who've said that they benefited a lot. And interestingly, also with stimulant use from baclofen, and felt that it was difficult to convince a provider to prescribe it for them. Do you have any evidence about that you can share about baclofen?
Yeah, the question was about baclofen as a medication for alcohol use disorder. And there is definitely evidence for baclofen for the treatment of alcohol use disorder. And it actually was listed as the first-line treatment for patients with alcohol-associated liver disease in the Liver Society guidelines for a long time. So I've seen a lot of patients actually treated with baclofen because of that. And some patients benefit. And if a patient is asking you for it because it has worked for them, I would say, yeah, try it out. But the thing to be aware of is that there was a large study from France that showed that at high doses, baclofen was associated with increased risk of hospitalization and death. These were very high doses of baclofen, and there was a dose response in that study. But because of that, I haven't considered it sort of first, second, or third line. But if you have a particular patient who's telling you that, I think it's totally appropriate and safe to prescribe it. And just monitor them for sedation and check in about how it's going before you increase the dose.
All right, we're going to move on. Triveni, that was excellent. We learned so much. Thank you so much.
Hi, everyone. Nice to see you. And thank you so much for inviting me for this presentation. And I think I just did something with oh. So while I'm fixing the slides, I am going to talk about treating tobacco use disorders among people with HIV. And the focus of the talk is really around treating tobacco use and primarily the medication aspect of it, but I will talk a little bit about counseling as well. And here they are. So a lot of my slides are adapted from Prescription for Change, which is a UCSF School of Pharmacy-based resource, which is free and accessible to everyone. If you want much more in-depth information on how to address tobacco use in different populations, this is a really good place to go to. So I'm going to talk about the epidemiology of tobacco use in general and among people living with HIV, discuss methods and resources for smoking cessation counseling, and discuss pharmacological treatments for smoking cessation, particularly among people with mental illness, and also controversies around using e-cigarettes for smoking cessation. So in the United States, we've come a long way from 40 to 50% of our population smoking to now around 11%. The 28.5 million people in the US use a tobacco product, 12.5% use cigarettes, about 4% use e-cigarettes or cigars, 15% use any form of combustible tobacco. There are differences by sex. Men are more likely to use than women. And there are differences by race ethnicity as well, with 39% for American Indian, Alaskan Native populations. And we're talking about commercial tobacco use here, 21% for white, 19% for Black, 11% for Hispanic Latinx populations, and 11% for Asian. There's also a difference by region, which reflects strengths of tobacco control policy, with higher prevalence rates in the Midwest and South compared to the East, the coasts. So this brings us to the first question. What is the prevalence of tobacco use in people with HIV? Okay, so it's changing. Awesome. So you all are in the right ballpark. It is definitely above the national prevalence of 11%. It's around 47 to 65% of people with HIV who smoke. It is a very high rate compared to our national population rate of smoking. And in San Francisco, our prevalence is 10%. In relation to HIV, we know that tobacco use causes impaired T cell functioning. It may reduce immune response to antiretroviral therapy. And smoking is attributable to 24% of all-cause mortality, 25% of the cardiovascular deaths, and 30% of non-AIDS related cancers. And HIV positive smokers lose more years of life from smoking than from HIV. So we also know that there are confluence of other factors that are also linked with HIV. And these factors are very much associated with tobacco use and really highlight structural inequities that have contributed to high rates of tobacco use among some populations. And these include those living below the federal poverty line, who experience homelessness, who have a history of legal system involvement, who identify as sexual gender minority, who use substances and have mental illness. And these populations have much higher rates of tobacco use and also disproportionate burden of tobacco-related illnesses. So treating tobacco dependence is a two-part problem. There is a physiological component, which is the addiction to nicotine, where there are medications for cessation, and the behavioral component, which is the habit of using tobacco, where a counseling program can help. The combination of the two is really what is guideline recommended tobacco treatment. So let's start with our first case. Mr. P is a 55-year-old man with HIV, history of chronic obstructive pulmonary disease, homelessness, polysubstance use, traumatic brain injury, and mild cognitive impairment and schizophrenia. He smokes 1 pack per day. He has a 40-pack year history. He lives in an SRO in the Tenderloin where smoking is allowed indoors. He's now ready to quit smoking, stating, "I will never quit smoking." He's prescribed olanzapine for schizophrenia, and he is on antiretroviral therapy. So what are some of the questions that you can ask? This is not something where you need to respond, but people oftentimes wonder how to start a conversation around tobacco use. And the two questions that really link with nicotine dependence are how soon after you wake up do you need your first cigarette? And if it's within 30 minutes, you are speaking to someone with high levels of nicotine dependence. And how many cigarettes do you smoke daily is the other metric of nicotine dependence, with 10 or more indicating high levels of nicotine dependence. And these two measures are really important because they help you determine the dose of NRT that you might want to prescribe in the future. Do you use any other form of tobacco or nicotine products? Recognizing that people are using multiple tobacco products, cigarettes being the most common, but people may also be using e-cigarettes, little cigars, which are marketed very similarly to cigarettes, and they have a tax loophole. They're not taxed as heavily as cigarettes, so they tend to be cheap for our populations, and that's the second most combustible form of common combustible form of tobacco. And then we also ask whether they smoke indoors or outdoors, knowing that when people take their smoking outdoors, it increases their chances of quitting. So there are several behavioral interventions that use cognitive-based behavioral therapy, motivational interviewing approaches, and these have been distilled into several rubrics. You may have heard about the 5 A's: ask, advise, assess, assist, and arrange. And the smaller or the shorter versions of 5 A's are ask, advise, refer, and ask, advise, connect. These can be done in an intensive approach, taking between 15 minutes to 30 minutes, or they can be done in a brief approach, taking anywhere between 3 to 5 minutes. But this is the essence of each encounter that you might have with a patient where you're addressing tobacco use using counseling. So let's move on to our second case, which is medications for cessation, using the same example of Mr. P. After you counsel Mr. P, he's now interested in smoking cessation, but not ready to set a quit date. What can you do next? So these are some resources from our California State Quit line. They've rebranded, and now it's called Kick It California because they address not only tobacco use, but also vaping. They offer resources in 8 different languages. You can connect with a counselor and get 6 weeks of counseling, and this is something that any of us can do. Okay, so why consider medications? It definitely reduces nicotine withdrawal. 50 to 70% of quit attempts are unassisted, and successful quit rates with unassisted quits is around 5 to 7%. When you add aids for smoking cessation, that includes counseling and pharmacotherapy, your quitting success increases to 30 to 40%. And these are the reasons why we should consider medications in combination with counseling. So there are several medications for cessation that are FDA approved. You've all heard of nicotine replacement therapy. The 5 nicotine replacement therapies that are approved are the gum, the lozenge, and the patch. These are available over the counter. And then the spray and the inhaler are the ones that require a prescription from a provider. The gum, the lozenge, and the patch are something that people can purchase over the counter, but we certainly should be prescribing them because they're covered by health insurances, including Medicaid. The only loophole that you might see is for someone who's only Medicare insured, where because some of these are available over the counter, not all Medicare plans cover them. In those scenarios, definitely reach out to the pharmacist because there are other options for people. The gum and the lozenge take about 20 minutes to kick in, which parallels the time of action for cigarettes. And the patch takes a little bit longer, and both the spray and the inhaler are pretty quick in terms of action, but they're also the least likely used NRT forms. There are 2 other FDA-approved medications for cessation. These include bupropion, which reduce withdrawals and cravings with the max dose of 150 milligrams twice a day. And then varenicline or Chantix, which mimics the nicotine reward pathway and is a nicotine receptor partial agonist. And they're used at the max dose of 1 milligram twice a day. And we'll talk about some of these things in just a minute on how to use them in practice. So in terms of comparative effectiveness trials and approaches, the consensus based on the evidence so far is that varenicline is equivalent to combination NRT. And then when you're prescribing nicotine replacement therapy, you want to use two forms of NRT. You want to use the long-acting patch with the short-acting gum or the lozenge. And it's the combination approach that is superior than using just a single agent form of NRT. The combination NRT approach is equivalent to varenicline. So you can start with either varenicline or combination NRT. 12 weeks is the standard, but extended duration is more effective. And there are clinical trials that have shown that these medications can be effective for over 6 months up to a year. So you can consider having people be on medications as long as they are taking them as prescribed for an extended duration of time past the 12-week standard duration. They can also be used to prime cessation attempts. And this means that people might be smoking at the time of taking these medications, and that's okay because they can help reduce consumption and eventually increases the chance of successful quitting. And you can start these medications 4 to 6 weeks prior to an attempt. Okay, so this is kind of small, but it's helpful to go through. And this is based on a review that Nancy Rigotti just did very recently, and it's a really good paper to look at. But how do you work through the 5 A's in clinical practice? So you ask all patients about tobacco use, assess history and pattern of tobacco use and preference for treatments that they've had or that they've tried and they would like, deliver clear advice to quit, and recommend a smoke-free policy for home or their cars, and offer and connect to treatment. So the first line options, like we just spoke, are varenicline or combination nicotine replacement therapy. You could do a choice of patch with the lozenge, gum, inhaler, or spray to control cravings. Second line treatments can be single nicotine replacement therapy products or bupropion. And if that is not successful, then you might consider a host of other options, including varenicline with nicotine replacement therapy, varenicline with bupropion, or bupropion with nicotine replacement therapy. So this algorithm is helpful, but I think the main takeaway is to remember that varenicline and combination NRT are the 2 first-line approaches. So just to review, what are the preferred first-line pharmacotherapy approaches for tobacco use, and select all that apply? Great, so we have a few options with some changes. So I would say, as based on the data so far, if I were offering tobacco treatment to someone and they haven't tried medications before, I might start with varenicline or combination NRT. If someone has tried those options and they would prefer others, then I would go on to the single agent NRT, so either the patch or the gum, or bupropion. It might also depend on how much they're smoking. A lighter smoker, maybe smoking 1 to 2 cigarettes per day, might be okay with a single agent NRT. Okay, so what are the medication considerations for people with HIV? So there are clinical trials for varenicline for people with HIV. One of the largest trials was done in France with 30 hospitals, and they found that varenicline was associated with greater abstinence and considered safe among people with HIV. Bupropion is okay to use, though there are no RCTs, and there is concern with bupropion because it may interact with ritonavir through inhibition of the cytochrome P450 pathway, and it may need dose adjustments. This doesn't mean that you can't use it. It means that there are reservations, and you might want to consider that depending on the antiretroviral therapy regimen. So there's a newer medicine called cytosine. This is something that is available in Europe and other countries. It is available over the counter for smoking cessation in those countries. And it's a plant-based alkaloid that is used as an OTC product in Central and Eastern Europe for decades. It is like varenicline, a partial agonist. It is not marketed in the US and it's not available, although now there are a couple of recent randomized controlled trials that have shown high levels of efficacy, safety, and tolerability, and high rates of abstinence as well, that the FDA might review these applications for approval in the United States. So this is something, another medication that might be available to us in the coming years. So just in summary, NRT, varenicline, and bupropion can be used to prime cessation. These medications can be given weeks to months before a quit date. They have been shown to reduce cravings, reduce consumption, and increase abstinence, particularly when combined with counseling. Okay, so let's move on to our third case, which is medications for cessation of mental illness. So this is our same patient, Mr. P, has a history of schizophrenia and is treated with olanzapine. He continues to smoke 1 pack per day. You're wondering whether it's safe to prescribe medications for cessation because you've heard that treating cessation can adversely affect psychiatric outcomes. What would you do? So how would you treat Mr. P? Offer counseling and no medications because you've heard that there is a black box warning against varenicline, and the black box warning is actually right there, even though the writing is a little hazy. Offer only medications and adjust doses. Offer medications, adjust doses if not needed, and counseling. Cool. So everyone is in agreement. So there was a black box warning against varenicline that was taken out in 2016. The big trial that deemed that varenicline was safe for people with behavioral health disorders was the Eagles trial. This was an RCT of 8,000 participants, 4,000 assigned to the psychiatric cohort and 4,000 to a non-psychiatric cohort. It included 140 centers, 16 countries, and the treatment included NRT, varenicline, and bupropion for 12 weeks. And what the trial concluded was that there were no major neuropsychiatric side effects between people with psychiatric disorders and those without, and that varenicline was the most effective treatment in comparison to placebo, NRT, or bupropion. Since then, there were multiple meta-analyses of clinical trials that have confirmed that neuropsych side effects are not worse among people with mental health disorders, and that efficacy for varenicline is superior to the other options for treatment. It's important to note that those other trials only looked at single agent NRT. They didn't look at combination NRT. So it's very possible that varenicline and combination NRT are equivalent for people with mental illness. Okay, so in summary, cessation medications can be used safely in people with mental illness. It does not worsen mental health outcomes. Combination treatments may be necessary. Extended duration past 12 weeks may be necessary, and always couple with behavioral counseling. So let's move on to the last case. So Mr. P tried NRT, bupropion for an extended duration, was able to cut down to 25% of his cigarette consumption, and attempted several quit attempts. His neighbor recently introduced him to an e-cigarette and he wants to try it. What do you advise? So I can summarize the current evidence to date on the use of e-cigarettes for smoking cessation. And what the United States Preventive Services Task Force recommends is that the evidence is insufficient to assess the balance of benefits and harms of using e-cigarettes for tobacco cessations. That clinicians should direct patients to other cessation interventions with proven effectiveness and established efficacy and safety. And these include our 7 FDA treatment options. Ooh, I don't know what is going on with the slide there. The important thing to note is that e-cigarettes are not an FDA-approved cessation aid. And e-cigarettes are currently a consumer product. And what the studies have shown is that consumer product or consumer use of e-cigarettes, unsupervised and outside clinical trial conditions, are not effective in cessation. In fact, they are associated with high rates of dual use of both cigarettes and e-cigarettes that increase disease risk and does not aid in cessation. And we also have the parallel problem of increasing youth initiation of tobacco and nicotine products. So the recommended approach is to encourage use of FDA-approved aids for cessation. But there is evidence from clinical trials and a recent Cochrane review that showed that e-cigarettes performed similarly in efficacy to varenicline and cytosine. It's important to note that these are controlled conditions. These are regulated amounts of nicotine with regulated e-cigarette products that are used only for research purposes. Does not include all the e-cigarette products that are out there in the market that are unregulated. They looked at efficacy only up to 6 months, so long-term abstinence is unknown. Studies do not follow people for more than 2 years, so long-term safety is also unknown. And data on serious adverse effects are lacking, as most did not report them. So these are the caveats. So what would I do if one of my patients wanted to use e-cigarettes to quit tobacco use? So I would definitely encourage FDA-approved aids for cessation first. Go through, if they've used them in the past, what has not worked for them. And if people still want to use consumer e-cigarettes, then encourage complete cessation of combustible tobacco. And once they're confident in their tobacco cessation, then encourage e-cigarette cessation. And there's definitely a need for more evidence and strategies for vaping cessation. And our School of Pharmacy have produced these guidelines, which are based very much on how we treat tobacco dependence, where we include counseling. And you can use nicotine replacement therapy for vaping cessation, depending on if people are starting off using cigarettes and e-cigarettes or only vaping. So for example, if a patient has switched from smoking to vaping, then you start with pre-vaping number of cigarettes per day to guide the initial dose of nicotine replacement therapy. But if a person has only vaped nicotine, then you determine how much nicotine they're getting from their vapes and then dose NRT based on their total nicotine consumption. You can also use varenicline or bupropion. So I know that was a lot, but I want to end because I know we have a few minutes left. So it's never too late to quit. There are FDA-approved counseling and pharmacotherapy approaches, which are the standard of care. Pharmacotherapy can be used for smoking cessation, extended duration, and to prime cessation behaviors. They are safe to use among people with mental health and substance use. The consumer use of e-cigarettes are not FDA approved for cessation, and behavioral counseling and pharmacotherapy are also recommended for vaping cessation. So I'll stop there and I'm happy to take any questions. Thank you.
Thank you, Maya. That was fantastic and so important for our patients.
Hi, thank you. That was a great talk. I had a question about the mental health effects of Chantix because once something gets attached to a drug, it's really hard to shake people's perceptions of that. And the same thing seems to be happening with the weight loss drugs right now, despite a big trial last Friday in Nature that showed that there wasn't suicidal ideation with GLP-1 agonists. So how do you counsel, how do you help people shake that perception? Because it's both with providers and patients.
Yeah, it's a very good question. There is still a lot of reticence to prescribe varenicline for that reason. And I think that it's important to come back to these clinical trial data to say that they have been done in many different contexts and many different settings. And that, we do have we do have good experience of prescribing these medications for many years for nicotine dependence without any adverse effects. You could also do a trial and see, if people are willing to do like a 1 to 2 week trial to see how they feel on these medications. And then based on their approach and based on how they feel to continue for a longer duration of time. So a graded approach can be really helpful. But I do think, spreading the word and increasing awareness that these medications can be used among people with mental illness is one big way to reduce the reticence among providers to prescribe it.
We're almost at time. I'll ask one last question. Can you advise if the issue with contaminant in Varenicline has been resolved?
Yeah, that's a good point. I think it has. There was a time when it was pulled off, but yes. Yeah.
Thank you so much. There are a couple questions in the chat that I may come up and ask, but let's close. Thank you so much, both of you.
And just thank you. Thank you. That was so fantastic.